Hello, I'm Brian Miles, a urologist here at Houston Methodist Hospital, and I'm going to talk to you today about everything you might want to know about recurrent prostate cancer. There are things that on final pathology can make us worry that you're at a higher risk for recurrence. But how do we follow a patient? What do we do to know that the disease has come back? Well, I always start the discussion out in my office with a patient who has recurrent disease, and I point out to them, what did they do 40 or 50 years ago before PSA was around in order to know if the cancer was cured or not? Well, they got a bone scan every year, and suddenly 10 years later they say, golly, your disease has come back, it's in the bones. Well, a whole lot happened between these bone scans that maybe could have been treated differently. And that's where PSA has been remarkably helpful. PSA is prostate-specific antigen. It's how we find prostate cancer invariably at first. But it's very important after we treat prostate cancer because your PSA should become undetectable. Not zero, it won't go to zero, undetectable, which is less than 0.1. It'll be quite a bit lower than that, but less than 0.1 is considered undetectable. If the PSA starts to go up and go over 0.1 or 0.2 in some centers, we call that a biochemical recurrence, meaning we only know about it in the bloodstream, nowhere else. And so biochemical recurrences are a bit terrifying for the patient. And I point out that PSA stands for prostate-specific antigen, and my job is to make sure you don't believe it means panic-specific antigen. I have to calm patients down because there are many things that we can do. First, we would get an MRI of the pelvis to make sure there's not a new mass that has occurred down there. Invariably, that's negative. And then we follow the PSA closely every 4 months or so and to see what the trend is. If it gets over 0.2, 0.25, we then get a PET scan, prostate-specific membrane antigen PET scan, which can find very small volume disease, which we can treat independently. I will tell you that many urologists feel that when there is biochemical disease or biochemical recurrence, that the patient needs to get radiation to the pelvis. That's certainly not wrong. Here we have a team that works well together, medical oncologist, radiation oncologist, and myself, to see if we can help the patient pursue cure without blindly radiating the entire pelvis. Again, it's not wrong, but sometimes we think we could do that a little better. And to that end, when to do radiation, when to use hormone therapy with a medical oncologist, or even immunotherapy is something of great interest for most patients because we have a team here. And I'd like to introduce you to the members of the team who will speak about the issue of when do I start hormone therapy, when and where do we do radiation, and can we sometimes do spot radiation as opposed to whole pelvis radiation. Thank you for your attention. Hopefully this was of interest to you. I look forward to my colleagues providing more information. Thanks very much.